Good afternoon. I think we'll get started. Thank you all for joining our Romano clinical rounds. It's my privilege to introduce Dr. Tony Ahmed, who I had the pleasure of meeting along with a small group of us from our adult inpatient services when he and his team graciously hosted us so we could learn a little bit more from their experiences, and you'll be hearing more about that today. So we did invite him to present as we consider how we're going to move forward in dealing with patients in our inpatient services who suffer from aggressive and violent behavior. So Dr. Tony Ahmed is an associate professor of psychology and clinical psychiatry at Weill Cornell Medicine. He's also the vice chair for psychology in the psychiatric department and serves as the inpatient psychologist in psychotic disorders division at the Westchester Behavioral Health Center. Dr. Ahmed completed his doctoral training in clinical psychology at the University of Southern Mississippi and psychology internship at the VA Maryland Healthcare System. He completed a psychotic disorder postdoctoral fellowship at the Medical College of Georgia and Augusta University, and he's been involved in the development and dissemination of evidence-based interventions for people with schizophrenia. Over the last 5 years, he has been heavily involved in the multidisciplinary collaboration to really address the challenges of violence and aggression at his facility. Dr. Ahmed also conducts clinical research, including collaborations funded by Brain and Behavior Research Foundation, the National Institute of Health, and the Patient-Centered Outcome Research Institute. His academic work has been recognized by several scholarly and clinical awards. His presentation, as I mentioned, is timely because we are considering learning more from his experiences to really think about how we might be able to better address the needs of patients on our inpatient adult units who suffer from violent and aggressive behaviors. And we are looking into doing so over the course of the next year or so. So again, welcome, Dr. Ahmed, and thank you so much for joining us today.
Yes, thank you for having me. And thanks for the invitation to talk about the intractable challenge of managing aggression at a hospital. I'm going to share my slides. Are my slides visible? Let's see. Let me try it again. All right. Okay. All right. A couple of disclosures, but nothing I'm going to talk about is relevant to any of these disclosures. Those are objectives. Okay, so let's get to it. A lot of my work centers around working with patients with schizophrenia. That's my area of particular interest. Of course, schizophrenia is quite associated with an elevated risk for aggression, particularly impulsive aggression. And now, most patients are not aggressive, but with a few patients that struggle with aggression, aggression can be very impactful. And we're going to talk about a little bit about the impact of aggression. But many of the points I'm going to make are probably quite familiar to most of you since you work with a similar population. When we talk about aggression, obviously violence is the big thing, but aggression in schizophrenia is a lot of our inpatients can be physical, it can be verbal, it can be like object-related aggression or self-aggression as well. And most patients struggle with impulsive aggression. And when we talk about impulsive aggression, we're not talking about a premeditated form of aggression, but we're talking about an aggression that usually accompanies agitation or some kind of triggered emotional distress that decreases their capacity to regulate their impulse or think through their actions. The construct of of urgency or emotion-based impulsivity is especially relevant to not just aggression, but even suicidal ideation and actions, and just some of the associated constructs that I and my colleagues study in research. The aggression that we're talking about is aggression that's reactive, that's uh, related to some kind of loss of emotional dysregulation. Now, violence in a hospital setting has been on the rise. This is a well-recognized problem. It's been on the rise for just about the last decade and a half. This is some news articles and survey from the U.S. Bureau of Labor Statistics from 2020 that shows that there has been this remarkable elevation over time. Uh, the data that's depicted here is from 2011 to 2018. And the rate of increase has been especially remarkable in in the experience of the violence from, care recipients has been quite remarkable in healthcare. And this is especially elevated among healthcare professionals that work with psychiatric patients. So we're looking at a problem that's not only on the rise across all professions, but especially amongst healthcare professionals, healthcare nurses, and even much more remarkable among people working with psychiatric populations. And it's associated with remarkable costs. Again, this is old data from the national the U.S. Bureau of Labor Statistics, and they publish this data every year. So there's probably new data from 2024 at this point. And these were numbers from 2016 from a survey of 123 hospitals. Cost of inflation adjusted, you're looking at even much more elevated numbers. And a lot of the cost goes into sort of investing in infrastructure to manage violence or to repair infrastructure that's caused by, violence in this case in a hospital setting. And of course, some of this cost also goes into training new staff after your staff members quit because of the experience of violence from a patient. The pie chart at the very bottom shows that about 80% of the cost is due to something that's related to patient care. We over here, we're the Rochester Behavioral Health Center campus. We admit about 4,000 patients per year on just this campus alone. We have shorter time units where the length of stay is about 2 to 3 weeks, and we have one of the very few tertiary care inpatient units in the state of New York. That's not a state hospital. We have 12 inpatient units, mostly adult units, but we have two child adolescent units, and we are in the process of creating a 13th unit that is slated to be open in the next year or two. We have oversight of 220 beds on this campus. We have other campuses, but I'm going to focus particularly on the Rochester Behavioral Health Center campus. And we deal with a lot of specialty presentations, including the psychotic disorders units that I cover. We have mood disorders programs, we have personality disorders programs, we have young adult programs, and so on. So we're quite we covered a range of specialty quite a bit. We started to we've been experiencing the same problem in our hospital system, including this campus. And in the last couple of years, like right about when COVID hit, we really started to worry about staff experience of assault from patients. We saw this rise in injuries. We saw of course, I'm only showing data that relates to physical aggression in this case, including patient-to-patient injury from assault, or patient-to-staff injury with assault. Everything was on the rise. So you will notice in the second chart that it looked like the numbers went down from 2019 to 2020. I think some of that probably had to do with, you know, better operationalizing what we were capturing, number one. Number two, we 2019 was just a really, really, really difficult year overall. And a lot of the infrastructure that we have in place now to track this data very carefully and sort specifically what we're capturing has improved. And I'm going to talk a little bit about what we're using for that. I'm going to show an update to this 2021 number, hopefully at the end of the presentation. I've also struggled quite a bit with the numbers of restrictive interventions that we've had to use since 2019. The numbers from 2019 to 2021 were it was quite concerning. I wouldn't say that it got better in 2020. No, from 2019 to 2020, we appear to be using more restrictive interventions in our hospital across both adults and child care recipients. And that was part of what led to sort of thinking more systematically or more system-wide about how we deal with this. We were also experiencing a lot of damage to property. These were some numbers that I was able to put together when we were proposing like some of the system level stuff that I'm going to talk about. But I've been told by some of our staff members and some of our nursing leaders that these numbers are probably really, really conservative, that the damages that we tried to estimate here were just a slither of other damages that were caused by patient aggression and property damage and so on. Impact on staff is is a given. When patients experience aggression or when patients elicit aggression, it's distressing for everybody. Nobody is happy when they have to use restrictive interventions. I look at our staff when we're debriefing and they seem overwhelmed, it does contribute to a lot of dissatisfaction. They sometimes don't feel like leadership of the hospital is doing enough. It leads to a lot of potential disengagement from, like being part of the hospital treatment milieu. And, people resign, people call out, because of the impact that it has on them. It can be quite psychologically traumatizing for staff members when they have to manage a patient who is struggling. And some staff members may develop, if you will, some negative kind of transference towards patients who struggle with aggression and violence. And it's not easy for patients either. Like, it means that they experience, increased use of restrictive interventions. They wind up staying in the hospital longer. They are at higher risk for coming back to the hospital. Putting a patient in a physical hold or restraint can be traumatizing as well for certain patients, especially patients who've had a history of trauma. It can be quote unquote re-traumatizing, if you will, for them. And patients who struggle with aggression can also often at increased risk for victimization when other patients get back at them. Or even if, in extreme cases, if a staff member gets back at them. It contributes to a lot of mental health stigma, certainly in society. And patients who have to experience restrictive interventions or some of the attention that aggression brings in a hospital will get dissatisfied with their psychiatric care. So some of the risk factors are well established in the literature. Male, younger age, income and level of educational achievement, which does have some, especially educational achievement.
Yep.
Okay, all right. So some of these risk factors, some of them are, dispositional, unchangeable, or for the most part. Some of them are historical as well. The ones that are often readily modifiable relatively, relate to symptoms and substance use problems, cognitive impairments to a certain degree. If there are medical issues that are contributing to the patient's aggression, those are potentially modifiable as well. Okay. All right. Okay, now I can't advance my slides. Let's try again. Okay. For example, like, some of the studies that we've done, because we have access to this kind of population, we see, we've published or we've done some analysis where we've seen that cognitive functioning, for example, and the level of trait affectivity are important predictors of, or rather important correlates of someone's likelihood of engaging in impulsive aggression. We've looked at this with clinical rating scales, with behavioral tasks, some paradigms from cognitive or affective science, and found some of these associations. One of the areas, for example, cognitively, that you notice, and that you've probably noticed anecdotally as well in your own clinical work, is that when patients struggle with their memory, their reasoning and problem solving, their processing speed, those can be profound in patients with a history of violence, and that's what we've seen in some of our data. But even more remarkably, cognitive functions that have to do with processing social information. So understanding how somebody else is feeling, or understanding how somebody else's intention, or understanding social relationships, being able to process that kind of social information in a personal interactions actually has even more magnitude in predicting or correlating with how likely someone is to engage in aggression. In some of the data that we've collected, we see that some of these variables, like cognitive functioning, the level of symptoms, person's level of emotional awareness, how they are able to recognize when they are feeling distressed, and how they are able to communicate that level of distress, which is what we call alexithymia, when there's a deficit in that. We see that those variables like that, correlate with some aspect of aggression, whether it's a life history of aggression or ongoing recent aggression. And then there are emotion regulation. So there are all these milieu-based factors on the inpatient unit that can also be potentially targeted for decreasing aggression, including, like how staff members talk to patients, how patients are kept busy in the milieu can decrease the risk for aggression. And there's a whole lot of literature on that as well. Okay, so at our hospital, again, we have, there are certain things that we do on an individual level. There are things that you do on the milieu level, and there are things that you do on the systems level as well, that we've certainly tried. On an individual level, I'm not going to go into too much detail about this. Obviously, part of what you do is a comprehensive assessment, but there are a whole host of interventions that you may try. You might try adjusting their meds, like ECT, CBT, anger control therapy, their DBT, social skills. Part of what you might do in terms of behavior management, those will include the level of observations that patients have been subjected to, and if they are targeting another patient in the unit, you might come up with some non-interactive care plans, or use some restrictive interventions as necessary. These are usually in the realm of behavior management, in the realm of what nursing providers might take the lead on. And then there's behavior intervention planning. I think behavior intervention plans are probably underutilized in situations like this. They help you understand the function of the aggression when a patient struggles with aggression. And when you understand the function, then you can better come up with the alternative, right, in terms of in the context of a behavior plan. Some other ways for the patient to get what they want that's much more adaptive and much more conducive to the treatment milieu, could be part of what you think up in a behavior intervention plan. Usually your psychologist takes the lead on this, or your BCBA if you have somebody on staff. Now, the milieu level, when we talk about milieu therapy, we're talking about what do you do with the inpatient unit in terms of thinking of the inpatient unit as an ecosystem in which patients and staff members and everybody has to coexist. And what do you do with that community? The idea of milieu therapy is that the community of the unit itself can be an intervention, and you can get quite a bang for your buck. And so we've focused quite a bit on, like programming at the milieu level. And when you think about a milieu, you think about the features of that milieu. Like what is the structure? What does it look like physically? What is what are patients expected to do in the milieu? Like how what are their routines? What are their what are the rules of the milieu that can potentially promote wellness for patients? And then the other piece of it is thinking about how communication happens in that milieu. How do you give patients positive feedback, and how do you give them corrective feedback, and how do you make sure that it's consistent? What is the culture of the unit at the end of the day? Like how is your milieu as a program addressing cultural or things that are culturally sensitive or issues that are culturally sensitive to promote like an overall sense of wellness and belonging for care recipients in that program. A lot of what I advocate for in the context of milieu therapy, includes sort of leveraging early interventions. How do you use early interventions in the milieu as a staff to help patients regulate before crisis actually happens. And when you implement milieu therapy, it's all hands on deck. Yes, you might have one discipline that sort of informs your theoretical practice, but everybody has to speak the same language to foster that sense of community and to foster that sense of consistency. These are some central principles that the literature supports. For any milieu, you want to make sure that patients are busy, that your rules are fair and consistent, you keep your noise down, and that you make sure that your staff members are spending time with patients outside of the nursing station. You want to make sure that your communication is collaborative, that it's egalitarian, that it's autonomy promoting, and transparent about what's going on. Spending time with patients can be rewarding for them. A lot of times when the time patients get our attention is when they are struggling, right? And the idea here is to make sure that our one-on-one time with patients is not contingent on them having an aggressive episode. And then we want to make sure that, we're leveraging some of, some milieu-based techniques like positive reinforcement. So a lot of what we've promoted at our hospital comes from our second chance program, which I'll reference like briefly, which, your own Dr. Steve Silverstein at University of Rochester, went in his early career, created our program for us. And, and it's been central to sort of a lot of the culture of giving feedback that we've disseminated around our hospital. And like I said before, early interventions, leveraging early interventions, sensory-based techniques, integrative approaches, and of course, being mindful of trauma and to the extent possible, being intentional about limiting our use of control interventions. So these are some examples of milieu-based programs in our hospital. Like I mentioned, the Second Chance program, which influenced a lot of the other ones. We have programs that are based on a CBT approach or a CBT like kind of language. And we have some programs that are based on a DBT approach in the sense that a lot of the staff members get that kind of DBT foundational skills training as part of how they communicate. Like the young adults program, which we created and we disseminated across our campuses, for example, leverages that model. An example of like in our child unit, for example. So we're starting to see some, or rather like this sort of milieu-based approach seem to have an effect on that particular unit. Just using that as an example of leveraging a milieu-based approach. So at the systems level, there are three major innovations that we've tried to implement on our campus. The first was creating a violence reduction subcommittee, which I'll talk briefly about. The psychiatric ICU and our positive behavior support, program that we created for the hospital to target patients with, intellectual disabilities and patients who may struggle with autism spectrum disorders. Okay, the PBS team is a consultation group that we created. Okay, so the violence reduction subcommittee, this includes about 35 members. The number changes and evolves from time to time, but this is essentially our multidisciplinary steering committee for the oversight of our practices or our attempts at violence reduction. We started that in 2020. We have monthly meetings. We're mostly nurses, but we comprise nurses and mental health workers and psychiatric technicians. We have some of our physicians are involved as well, and social workers, and as well as our hospital, the head of our hospital security as well. And some of our objectives include creating a system for monitoring incidences like this in the hospital, and playing Monday morning quarterbacking around these incidents. Creating staff training and practice standards for our hospital. Leading the effort to reduce the use of control interventions. Advising on the modification of the unit ecosystem, addressing staff well-being, championing patient-centered interventions and helping out with consultation around those, and taking the lead on the quality improvement. The head of our violence reduction subcommittee is also the head of our hospital quality control. So with surveillance, for example, one of our innovations was the creation of this behavioral health dashboard on the backdrop of our Epic. We use Epic in our hospital. So on the backdrop of our Epic system, we created this dashboard which allows most of us to, in fact, all of us to get easy access to what the numbers look like. It also, the dashboard collects a lot of information that allows us to analyze each incident. We communicate the data to the units so that the units are well aware. It is my view that much like for patients to control their aggression, they have to be able to monitor their own emotions, right? In a similar way, for us to help the hospital manage aggression, we have to be able to track where the aggression is happening. So, and then the staff training, we help the hospital with designing curricula for de-escalation, trauma-informed care, and responding in emergencies. The OMH trust training is a standard training for a lot of OMH facilities in the state of New York. So we sort of help with fostering that, and we help with developing protocols for managing or tracking early warning signs and developing preventative strategies as well as helping the staff debrief when incidents happen. And then, we also focus on, like the experience of or reducing restrictive interventions. Like when they do happen, we keep track of them with, we have, like protocols for, thinking through how the decision was made. Staff members complete a keep safe during those incidences that allows us to review those incidences as well and codify those incidences as a team. And then we reviewed the milieu as well and advice on the milieu, like I mentioned before, including how staff members are structuring the milieu. We advise anytime a unit is being renovated, we advise the hospital on how to structure the milieu, the unit during the reconstruction, so that it's conducive and therapeutic for patients who struggle with aggression. And then we part of our objective is focusing on decreasing harm to staff members. So we champion wellness initiatives, like you know, like after crisis incidences, the debriefing and review. We review WorkSafe. The WorkSafe system is like an event review tool that was created for our hospital to document and record incidents of staff experience of aggression and assaults. And the keep safe also the work safe also allows us to keep track of these incidences. Like I mentioned before, we're coding those incidences with much more accuracy than we used to. And then, we provide guidance and feedback on behavior intervention plans when those are implemented on inpatient units. And when there's an incident on the unit, they present, like a particularly profound incident, we might invite some representatives of the unit to come to our violence reduction subcommittee meetings, and we talk about the incident. It's not to criticize, it's not to tell them what they are not doing well, but it's to provide support and to provide technical advice on like how to restructure the plan if necessary. And then we, are also involved in, sort of helping, like the hospital with particular guidelines. For example, like rules of the unit that may be potentially provocative for certain patients. We provide some feedback on those kinds of rules and how to restructure them. We help units, with, like communicating information about their own struggles to the hospital leadership. And then we also advise the hospital on particular program development initiatives that we think can be very helpful. An example being the PQ and the PBS team. So let's talk about the PQ, right? So the PQ started at the end of November 2021 when we piloted it. We created a unit called the Psychiatric ICU, and our goal was to, in creating this unit, was to have a unit where we could bring to bear a lot of the expertise that's actually available, in our system. We have, like staff members that are very good in the hospital. We have staff members that are very good with patients who struggle with aggression, and we have people who study aggression as an area of interest. So when we created the PQ, we wanted to pilot a unit where we could provide focused care and services for patients like that, and also take some of the burden off of the regular units. And I'm going to talk about the process that we created to interdigitate with some of the regular inpatient units with these patients. In creating the PQ, we came up with some committees who were going to sort of inform how that program was created and initiated. So, for example, we had an admissions committee that helped define what kinds of patients were going to be admitted to the unit. We had a staffing committee that helped us determine the qualification of the staff that was going to be working and rotating through that unit. The education committee had something to do with like what kind of training that particular staff is going to need. So they helped us with that. And then, we had a programming committee that would tell us what kinds of, interventions were going to be provided in the program, as well as what the unit was going to look like. And then we had a program evaluation committee that helped us define what kinds of outcomes we were going to be looking at. So we generally target patients who are currently in the hospital struggling with aggression, and patients who are in an acute phase of illness. I'm going to talk a little bit about the admission criteria for those patients. A lot of the treatment that we provide in our program is very multidisciplinary. It's very collaborative. It's quite intense.
Good.
Okay, this is our process. So we admit patients in the PQ directly from our evaluation center. So the patients go to the evaluation center, like that's their first stop into being admitted. So they may be brought to the evaluation center from the ER, from the CPEP, for example, our psychiatric emergency department. Or we may admit patients directly from the inpatient unit. So, if a patient is struggling with aggression in the evaluation center, then they will admit them directly to the PQ. They will fast track them, which can be frustrating sometimes because we might wind up admitting somebody without much warning. But it's easier for us to get admissions from the inpatient unit because the patient's struggle with aggression is well documented, and we can communicate directly with a team that's had experience with them. And then when we work with them in the PQ, we might send them back to the unit that sent them to us, that referred them to us, or we may stabilize the patient, keep them on our unit, and then discharge them. Okay, the structure of the PQ allows us to do that. Like I said, the patients that we admit struggling with aggression, their primary diagnosis is usually a mood or a psychotic disorder. We won't, in the PQ, admit patients with a neuropathology, for example, or patients who have a primary diagnosis of a substance use disorder, but they can have a comorbid substance use disorder diagnosis and be admitted to the PQ. We also want to admit patients whose primary diagnosis is a personality disorder. And like I said before, we'll be sending back to after we've worked with them, we might send them back to the unit that referred them, or we might discharge them after stabilizing them. I'm going to skip this slide in the interest of time. But it's basically an example of a prototypical patient. When the patient got admitted, we not only adjusted medications, but we also created a behavior intervention plan for the patient, which includes a functional assessment of their aggression. We determined what it was. We created a behavior intervention plan. We implemented the plan, and we transferred the patient back to the unit that referred them with the behavior intervention plan. Now, we also have the option of actually helping the patient with their discharge planning in the PQ. On the long, we have a step down area in our unit for doing that. Again, I'm going to skip a couple of slides in the interest of time. The training curriculum for staff is very comprehensive, it includes some restraints and seclusion skills refresher, so that it's, except part of the refresher is also helping patients to get out of restraints and seclusion as quickly as is possible. Some behavior intervention planning was also part of the training, a lot of de-escalation training, de-escalation techniques, and then a lot of milieu management training as well. The milieu management training included things like how to use positive reinforcement, how to do a 3-step prompt to give corrective feedback in a way that's neutral, how to use, timeouts, how to use early interventions and so on, and how to plan those things. This is what the unit looks like. This is some of the staff members. It's a well-resourced unit in the sense that we have on the acute section of the unit, it's 17 beds, but we have 5 beds that are dedicated to the acute section. We have 1 nurse that covers those 5 beds, and 3 mental health workers or psychiatric technicians that support that nurse. And then the other side, the step down area of the unit has 12 beds. After we stabilize them in the PQ, we move them over to that, to the long end of the hallway. And then the long end of the hallway is a lot like a regular unit in that sense. Our rounding system is very unique in the sense that we do 2 rounds during the day, and it's a flat hierarchy. Psychiatrists and psychologists don't lead the rounds. It's much more of a egalitarian, flat structure. The mental health workers, we trade information with them. When I say mental health workers, I mean the floor staff. They take us to each room to have conversations with the patients. And a lot of the behavior intervention planning and the therapies that are provided are very collaborative as well. Now, the PQ doesn't is not tailored for people with intellectual disabilities or people with autism spectrum syndromes. And that's why we created our positive behavior support team, right? So part of what we noticed that was also contributing to aggression is that we were getting a lot of patients with autism spectrum disorders. That started to happen again also in 2019 as well. We can talk about sociologically what happened in society to foster that. It's not just our hospital, it's a lot of hospitals in the state of New York. And unfortunately, we didn't have a lot of staff that had training in autism or intellectual disabilities. So there was quite a gap in the knowledge and experience dealing with these patients. And so the PBS now, luckily for at least for our campus, we have the Center for Autism and the Developing Brain, which was created as part of our partnership with Columbia University and New York Presbyterian Hospital. So my department and New York Presbyterian Hospital and Columbia created the Center for Autism and the Developing Brain, and that had existed on my campus for several years. So part of what we did was we were able to leverage that by, sort of using their expertise, because I do have faculty members that are part of the Center for Autism and Developing Brain. So we were able to sort of invest in some of their time to provide consultation services, and that became the PBS team, the Positive Behavior Support Team. So the goal here was to sort of improve the experience of patients with autism spectrum disorders and try to decrease their length of stay. We don't have an inpatient unit that's dedicated to autism spectrum disorders or intellectual developmental disabilities. If you do, well, part of our rationale was that it would have been logistically challenging for us because the resources that are available through OPWDD for those patients are very limited. So if you create it, you're going to wind up with patients you won't be able to discharge. So a lot of the patients with autism winded up being distributed across all of the units. I got several of them in the Second Chance program, on the psychotic disorders units for management, which was very challenging for our staff. So we needed this PBS team to provide ongoing consultation and support and resources. And so the components of the PBS team includes providing direct clinical care, providing staff training for this in managing or working with these patients, and also some educational experiences for our trainees and some quality initiatives as well. So I'm going to skip this slide so I can get to some of the services. So they help us with discharge planning. They help us with some functional assessments of challenging behaviors when it comes to these patients. And there's this sort of, bi-directional process that each unit has with the PBS team that includes the PBS team comes in, they bring their expertise, they tell us what to do, and we try those things out, and we refine those plans in communication with them. They meet with the team that referred the patient for consults a couple of times a week to kind of make sure that the plan is going really well. In terms of our investment in it, we invested in the time of a psychiatrist, the speech language therapist, a psychologist, a BCBA, occupational therapist, and administrative support. You'll notice that the investments that we did here are fractional, right? So meaning that this particular faculty members or hospital staff members have other jobs, but we bought some of their FTE time for this innovation. I'm going to skip this as well. So just show you a couple of quick stats before we finish. The PQ is still ongoing. The 138 patients that were stabilized, this was within a 1-year period from 2023 to 2024, I think is what that number is. It's, some of our patients, a few of the patients were readmitted to the PQ after we sent them back to the unit that referred them. Again, that's not unusual. Sometimes you might communicate a behavior intervention plan, and maybe the unit struggles with implementing that plan, and you get the patient back. It's the nature of the beast sometimes. The average age of the individual admit is about 38 years. low levels of education for the majority of them. They're mostly males, obviously, mostly with a schizophrenia diagnosis, and a lot of cognitive deficits as well. So, like, to kind of update, like, show you what our I can hear you. So, like, we think the numbers are trending in the right direction, but this remains a challenge. Okay, yeah, like if you have 39 assaults on staff that led to injury, that's still 39 assaults more, too many, right? But a lot of our innovations started at the end of 2022. We think that we are making a little bit of a dent. But again, this remains a challenge, and we have had to invest in this effort quite a bit. The risk of getting injured from all of those assaults is still over 30%. So, but we are making trends. We're, I think, moving in the right direction in terms of our use of restrictive interventions in both our adults and in the child adolescent units as well. But again, these numbers represent just the raw numbers. It doesn't take into account the number of actual admissions or the level of acuity of the patients. But but in terms of the trend, we think the trend is moving in the right direction, but not where we want it to be. The bar graph to my right, that's the number of actual safety watches. And we have those numbers from our nursing team. The number of safety watches. Now, this is not unique to just aggression or violence alone. This also includes other kinds of problematic behaviors, including suicide attempts or suicidal ideation or self-injurious behavior. So, but again, in terms of the numbers, like 2022 and 2023 was still high, but again, we think we want to decrease that because of the cost. So we're making some dents in that respect as well. Okay, so I'm going to finish here. I think some take-home messages is that this is challenging. It necessitates like thinking in a multi-systems way, multi-level systems approach. It has to be multidisciplinary. Like it requires investment, and it requires investment on the inpatient units in program development, but also investment in thinking at a system-wide level. Every discipline is important. Every discipline needs to be involved in that process because of how challenging it is. Across disciplines, we can still there's still enough literature out there that tells us enough about what contributes to the risk for aggression, which risk for aggression are modifiable, that are individual, that are ecosystem related, and a lot of what we can do at the multi-level systems approach can help us address those modifiable risk factors. So I'm going to stop here. Hopefully this was useful, and I don't know if we have do we have time for questions?
Yes, Tony, thank you so much, and thank you for your patience with all the connectivity issues.
Yeah, that was puzzling.
And thank you to our audience as well for hanging in there. And I think we still got the message, and also very remarkable what you and your team have been able to accomplish and the time and effort it took to develop this program and the ongoing work and commitment that it takes. Very much a model for what we'd like to be able to do here over the next year or two as well. Any questions from those in our audience?
Our microphones are on, so you can just talk. You don't have to. Yeah.
Thank you again for that presentation. It was very engaging, and you really gave us a broad overview. My question is about the instilling confidence and creativity in the staff members. You mentioned, I think 39 or 30% of the staff members had been assaulted. And I wanted to know if you can just speak to the type of intervention offered them prior to assault and at following assault that helps with recovery and if they return back to working on the PICU, and how is that resolved and done, addressed?
That's a fantastic question. I think, when staff members, it's not just the staff member that experience violence, it's also other staff members that witness it, right, that get impacted by those incidences. I think a lot of what we've done in the last couple of years has involved education around this, but also providing, more through the Violence Reduction Subcommittee, for example, providing a lot of wellness resources for our staff. It's not just the education. I think sort of bringing them back and reframing around, the nature of the work itself, which they understand, but also allowing them to letting them understand that they do have the autonomy to not, that we can provide allowances for them to not work with those patients if they are uncomfortable. What we've now noticed, because we do have some data on this, we administered this scale called the medical regards scale. It's a measure of staff sense of self-confidence with a specific population. And we administered that measure before we rolled out our training in advanced milieu, all of the trainings that we provided. And what we noticed was that the conversations that, not just the information, but the process of exchange that staff members were able to have with each other and trade skills and trade ideas, but also the encouragement that they were able to give each other that, well, it's not it's not you, it doesn't, part of what you don't want to do is, provide feedback in a way that chips away at anybody's confidence. So what we found is that those training experiences and those processes and the debriefing process and the feedback that we provide consistently has really helped staff members remain motivated and engaged, but also providing them with, the encouragement and the option to not work on a unit or with patients that they're uncomfortable with. What we did with the PICU, remarkably, this has been in the PICU, we've seen very little of that. Okay, that tends to happen more in other units that are not specialized for that kind of population. And part of that is what we've done in terms of how we rotate, and how we engage patients in the PICU. Our rounding is a team approach. We don't allow any of our staff members to do rounds individually. There are no individual rounds in the PICU. We round as a team, okay? And one of the mental health workers that are on the floor lead that rounding. And that's also allowed all of our other disciplines like social work, my psychology trainings, physicians to feel comfortable with patients in that unit because they have the support.
Great, thank you. I think we have time for one more quick question. Tony, one comment was what do you think about the role of hospital or unit design in reducing violence? One example is the empath unit. Any experience with that? Using calming, supportive atmosphere with light, music, etc.
Yes, I think there's good literature. There's some literature, on the physical structure of the milieu, including your creation of comfort rooms, and yes, the noise level of the unit, the lighting conditions of the unit, and we took all of that into consideration in the creation of the PICU. If you walk in there, you know that you'll get a feel that yes, this is a different kind of environment. Part of the way we've structured it is to allow patients to have their own individual bathrooms, for example, and provide activities in their own room, certain things that can keep them engaged and occupied, including activities that could be soothing and calming for them personally. The kind of music that's played in the milieu also promotes relaxation. So yes, I agree with all of that. That yes, I think, like the Impact program, for example, certainly leverages a lot of those physical structure ideas. Definitely.
Great. Well, thank you so much. We really appreciate you taking the time to share your experience, and hopefully we'll be in touch and continue to learn more from your team. Thank you so much.
Thank you for having me. Thanks so much.